I want to just go back and review how we got to TAILORx, how we got to RxPONDER, and those results and the data gaps that are left after those two large randomized trials, and what we're going to do to fill those data gaps. So this is old news. How did we get there? The Oncotype came on the market in 2004, and in order to validate the assay in patients who were lymph node negative, they went back to an old trial called the NSABP B20 and said, okay, Oncotype, it's 21 genes, you get a score of 0 to 100, but it's prognostic. If you just give that woman tamoxifen, you can say what her 5 and 10-year outcome will be, but how important is prognosis here? And the question is, who benefits from chemotherapy? And can we predict benefit from chemotherapy? As opposed to just being prognostic, yes, you have a poor prognosis, so you just need chemotherapy, but many women don't benefit. And so the NSABP B20 trial, the black lines here are the patients from the overall trial. The dotted line are the women who just got tamoxifen alone. You can see there's about a 5% overall improvement in outcome if you give the women chemotherapy in this trial. And when we got the blocks from the patients in this trial, we saw that we had a low score, which was 0 to 17. Those are the green lines. There's no chemo benefit. And if you get an intermediate score, that is 18 to 30, there's no chemotherapy benefit. And all of this chemotherapy benefit seems to be in this range of 31 to 100. It's an amazingly high amount of chemotherapy benefit. It's a relative 75% improvement in outcome if you give chemotherapy to women who are in this range. And that to me is consistent with the 50% benefit you get if you take endocrine therapy and you're ER positive, or the 50% improvement in outcome if you take trastuzumab and you're HER2 positive. This is very, very predictive when you're in that range of exquisite chemotherapy benefit. So that then led to the TAILORx trial. You're all aware of this trial. This is 10,000 women. And the real trial are those who had a recurrence score 11 to 25. And the question was, why didn't we keep that 0 to 17, 18 to 30, 31 to 100? Why were we messing with this intermediate group? And it's because the National Cancer Institute in the United States said, we see this massive chemo benefit when you're getting close to 30, 31, and we don't want to randomize those patients. They may end up on endocrine therapy and we could do harm. So we're going to bring down the score for the patients to see where the chemotherapy benefit is if your score is 11 to 25. So it's very hard to show prediction if you're going to shorten the patients who you're randomizing to chemotherapy or not. If you take all women who have a score of 0 to 100 and you say, can we predict who will and will not get chemotherapy benefit? Absolutely, you will show prediction. If you narrow it to 11 to 25, it's very hard to show prediction if it exists, because chances are there's very little chemotherapy benefit in that range. But nevertheless, TAILORx was set up that way. And when they looked at those patients with a recurrence score 11 to 25, after 9 years, there's no chemo benefit. There's no chemo benefit for disease-free survival. There's no chemo benefit for distant recurrence. And then they said, well, we didn't spend tens of millions of dollars on a trial to show no chemo benefit. Maybe somebody's getting chemotherapy benefit when they're 11 to 25. So they said maybe large cancers, maybe cancers that are 4 centimeters, 5 centimeters, maybe they're getting chemo benefit if they're 11 to 25. And the answer is no. There was no chemo benefit. Maybe grade 3 versus grade 1, no chemo benefit. Maybe large cancers that are high grade versus small cancers that are low grade, maybe you can see chemotherapy benefit there. No, we did not. If you're 11 to 25, there's no chemo benefit except related to age. And so on the right-hand side are the women from TAILORx in that 11 to 25 range who are over the age of 50. And they're not getting chemo benefit. 11, 25, there's no benefit. But when you look at the women who are 50 and younger, you start to see the chemotherapy benefit begin at a recurrence score maybe around 14, 15, in that range. And then the curves widen. So when we took that curve on the left and we made these graphs to try to make it easier to see, the group that's 0 to 10 only got endocrine therapy, but the next group over is recurrence score 11 to 15. If you are young and you have a recurrence score 11 to 15, there's no chemo benefit. When you're at 16 to 20, you start to see a little benefit. And then 21 to 25, it's really clinically meaningful, 6.5% absolute chemotherapy benefit. And most of these women just got 4 cycles of docetaxel cyclophosphamide. This is not dose-dense AC paclitaxel. This was really TC times 4 for the huge majority of these women. So then the next question that was asked, I know you're aware of these data because Dr. Sperano's come here to talk about these data, is what if we take this in the young women and we start to add clinical features to it? Can we improve on the prognosis of the score, which is very informative for who does and doesn't get chemo benefit, but can we be more refined to see are there certain populations who do get chemo benefit, especially in that 16 to 20 range? And that was these data that were published 1 year after the original publication in the New England Journal of Medicine in 2019, and they looked at what's called clinical risk. So high clinical risk or low clinical risk, it's binary. And clinical risk can be thought of as the rules of 4. If you take the tumor size in centimeters and you take the grade, and if that is over 4, it's high clinical risk. So if you have a 2.3 centimeter cancer grade 2, that's 4.3, that's over 4, that's high clinical risk. If you have a 1.8 centimeter cancer that's grade 2, that's 3.8, that's low clinical risk. That's how clinical risk is defined in this trial. It was defined that way in the MINDAC trial. That's clinical risk here. So when we look at that 16 to 20 group again, if they are low clinical risk, there's no chemo benefit. But when you're high clinical risk in that 16 to 20, there's pretty significant, I think, clinically meaningful chemo benefit. And then if you're 21 to 25, it's all significant in terms of how much chemotherapy benefit. And I'm saying clinically significant, clinically meaningful benefit. So that leaves us with some data gaps here. What do we do about these women? Because in this range, we know if they're postmenopausal, these numbers, they're not getting chemo benefit. Why are the young women getting chemo benefit in this range? And is it because a young woman's cancer needs chemotherapy for whatever reason? Even though we know her tumor size, all the clinical features, we know the recurrence score, it's exactly the same clinical situation for 10 years difference in age. Why does one group get chemo benefit, the other doesn't? And the open question is this from ovarian function suppression from the chemotherapy? And so it's a data gap. We need to answer that question. Do these women get chemo benefit because their ovaries are suppressed? So this then built on the node positive data. So we started again, 15 plus years ago and went back to an old lymph node positive trial called 8814. These women are all postmenopausal. And these women they had 1 to 9 positive lymph nodes, and they received tamoxifen for 5 years or CAF chemotherapy and 5 years of tamoxifen. And that trial showed several percentage benefit of chemotherapy for that group of women. And when we got the blocks from that tumor, it looked the same as the lymph node negative trial. If you're 0 to 17, there's no chemo benefit. 18 to 30, there's no chemo benefit. All the chemo benefits seem to be 31 to 100. Like, okay, that's very interesting. What percentage of patients, if we do a cutoff of 25, for example, say 0 to 25 recurrence score versus 26 to 100 that we're using from TAILORx and RxPONDER, What percentage of lymph node negative patients have a recurrence score of 0 to 25? And the answer is 85%. Only 15% of women are going to come in with a recurrence score of 26 to 100. It's even less if it's 31 to 100. If you're premenopausal, node negative, we don't see chemo benefit up to a recurrence score of 15. That's 50%. 50% of women who are premenopausal and node negative have a recurrence score of 0 to 15, where they will not see chemo benefit. So the huge majority of women don't need chemotherapy. But we need to fill these data gaps. So we went on lymph node positive. We saw this. They did the responder trial. When they looked at the curves from the patients from that prior trial, SWOG 8814, the gray line there are the women who got tamoxifen alone, and the orange line is the 5-year outcome of the women who got chemotherapy plus tamoxifen. And you can see that the curves are uncrossing around a recurrence score of 19 to 20. And they knew these data when they created the responder trial. And they said, okay, we're not going to randomize women above 25. There's just too much risk that we'll randomize someone just to tamoxifen or endocrine therapy alone, and we're going to undertreat them. So we'll power the trial, take women 0 to 25, and put enough patients in the trial to see if we can see that separation. Where does chemotherapy benefit begin if you are lymph node positive? So responder was powered to see that crossover at 19 to 20. And so they took 5,000 women, pre and postmenopausal, and only recurrence score 0 to 25. So over 9,000 something women actually had an Oncotype test. A bunch of them dropped out because they were 26 to 100. But then a bunch of women dropped out and didn't want to be randomized on the trial because they came in with a really low score. And they didn't want to be randomized to chemotherapy. So these are the brave 5,000 women who agreed to the randomization to endocrine therapy alone with or without chemotherapy. All 1 to 3 positive lymph nodes. Micromets are included in responder. They are not in TAILORx. So what happened is after about 2,500 randomized patients, they decided to stop accruing women with micromets only because they didn't want a trial that was just kind of like TAILORx, only a little bit of tumor in lymph nodes. They wanted enough patients with macromets and 1, 2, or 3 lymph nodes. And so they've reported the data multiple times now. It's been reported, published once, reported twice at the San Antonio Breast Cancer Symposium. And every time they do some kind of new statistical analysis. The 2 big endpoints that we're going to talk about are invasive disease-free survival and distant recurrence-free interval. Invasive disease-free survival is 5 things. Death from anything, death from breast cancer, distant recurrence, local recurrence, or you develop some other malignancy while you were on the trial. And if any of those things happen, that's an event and it's counted against that randomized arm. Distant recurrence is you develop distant metastases or you died from breast cancer. And I would say it's hard to die from breast cancer without having a distant metastases. So those are the same. The primary endpoint, though, is invasive disease-free survival. And on the most recent presentation, actually in the publication, there's an absolute 1.2% difference between giving chemotherapy or not. It is not statistically significant. But they knew about the TAILORx data. These patients were stratified by their menopause status. And the question is not age, but menopause status in this case. So the question is, how did they define menopause status for the responder trial? So a couple things you can observe. Of the postmenopausal women who are in this trial, almost everybody is 50 and older. There's only a couple percentage of patients who are under 50. But for the premenopausal patients, 30% are over 50. So there's, in the United States at least, the average age of menopause is 52. So you would expect to see this. In order to be postmenopausal in this trial, you cannot have had a period for the last 12 months. If you have a uterus and ovaries, if your ovaries have been removed, you're automatically postmenopausal. To be premenopausal, you had to have had a period within the last 6 months. So let's say you're somewhere in between. Let's say her last period was 8 months ago. Oh, is she pre or postmenopausal? Then you were assigned your menopause status by age, around over and under 50. This is the definition of pre and postmenopausal for this trial. The definition of pre and postmenopausal was different in TAILORx. The definition that they're going to use in the upcoming prospective trial is different from either of the two trials. So we're getting a little bit of heterogeneity in terms of people's definitions. If you are postmenopausal, you have 1 to 3 positive lymph nodes, and your recurrence score is 0 to 25. And your lymph node positive, if your lymph node negative, that's 85% of women, postmenopausal. Recurrence score is 0 to 25. If they're lymph node negative, if they're lymph node positive, 85% of women will have a recurrence score of 0 to 25. Node positivity doesn't cause a shift in recurrence score ranges for women. There's no chemo benefit, 0 to 25. Okay, so this was 3,300 women, strongly powered, so maybe somebody got chemo benefit if they're postmenopausal 0 to 25. No. Didn't matter how close they were to 50, didn't matter whether they were grade 3, didn't matter if they were T2 to T3, didn't matter if they had clinical risk, high clinical risk, low clinical risk if your node positive is a grade 1 cancer up to 2 centimeters. Anything above that's high clinical risk. 1 node versus 2 to 3 nodes. What if she's 3 positive lymph nodes and she's got a recurrence score of 20 and she's postmenopausal? She must be getting chemo benefit. No, there's no chemo benefit. And then they divided it 0 to 13, 14 to 25. They just couldn't see any postmenopausal group getting chemo benefit. Premenopausal, different story. Just like TAILORx, there's chemo benefit. For invasive disease-free survival, those 5 things, there's about a 5% absolute chemotherapy benefit, a little over 5 years of median follow-up. For distant recurrence, it's at half that. It's about 2.5% absolute chemotherapy benefit for the entire range of 0 to 25. 0 to 13, it's a smaller amount. 14 to 25, it's a little larger amount, but that whole group seems to be getting chemotherapy benefit. And the question is why? Is it because young women's cancer needs chemotherapy? Or is it because the chemotherapy is shutting down their ovaries and they're just getting an extraordinary endocrine therapy? So they did forest plot, lots of analyses of subgroups. Did anybody not get chemo benefit if they're premenopausal? And the only group that seems to fall out are women who are 50 and older and premenopausal. And they're the only one who's sitting with a hazard ratio of 1, but a pretty wide confidence interval. And I get a lot of calls, okay, my patient's 52, and she's still having periods, and do I think she's pre or postmenopausal? And in this case, we're just not seeing chemo benefit in that group, 0 to 25. So that leaves us with a couple questions. How about micromets? When I think about micromets, I always thought they're somewhere between node negative or node positive. Let's look at the young women in this trial, and let's look at the women who had micromets. Maybe they're more like TAILORx patients. They don't get chemo benefit until their recurrence score is over 15. And the other thing they wanted to look at is, what happens if you're premenopausal, you have to have had a period within the last 6 months, and your periods stop on the trial, whether you're randomized to endocrine therapy or randomized to chemotherapy? Do the women do better if their periods stop versus those who continue to have periods? And so 2 issues. One is on the left-hand side, the curves on the premenopausal women who had micromets, they're getting chemo benefit. So they don't seem to act like TAILORx patients, they're acting like the responder patients. The second is periods. So they said, okay, you have to have had a period within the last 6 months. Get randomized. We'll start doing case reports on women every 6 months as to whether they're still having periods or not. So that was built into the trial. Women were keeping menstrual diaries. And at the 6-month period of time, you can see on the gray, those are the women who are getting endocrine therapy alone, mostly tamoxifen. Half of them have stopped their periods, just on tamoxifen alone. And then the orange line are those women who got chemotherapy in that first 6 months and then started on their endocrine therapy. Only a quarter are still having periods. Okay, well that's interesting. And over 5 years, they're having less and less number of women who are having periods. You'd expect that. They're aging by 5 years. But what's really interesting is the outcome. If your periods stop, whether you were on endocrine therapy alone on the left or you got chemotherapy plus endocrine therapy, you do 50% relatively better if your periods stop versus don't stop. That's huge. It's a 50% improvement in outcome. We hope any of our therapies do that. And I would say if these patients are lymph node positive and they're premenopausal, the message I get from this is if you aren't shutting down their ovaries, if they're still having periods, you are undertreating these patients. They need to have ovarian suppression. Whether the chemotherapy is having an effect here or not is not known. Okay, so just to wrap up that whole thing, postmenopausal women, lymph node positive, 0 to 25, no chemo benefit. Premenopausal, we couldn't find a group of women who didn't get chemo benefit, except maybe those women who are 50 and older and premenopausal. Okay, so NCCN changed their guidelines. I don't know what guidelines are followed here in Israel. In the United States, people follow the one that kind of follows their bias. But the NCCN said for postmenopausal women, if you're node negative and 1 MIC, 1 to 3 positive lymph nodes, you should strongly consider doing an Oncotype assay. And then if the results, recurrence score is 0 to 25, do not give her chemotherapy. And if it's 26 to 100, this is the group you should start to think about giving chemotherapy. N2, N3, we don't have adequate data to know what to do with these patients. They're not randomized in any of these trials. Premenopausal women node negative, strongly consider an Oncotype. Recurrence score 0 to 15, give her endocrine therapy. If you think she's high enough risk, then add in ovarian function suppression, but there's no chemo benefit there. 16 to 25, now you have some decisions to make. How strongly do you believe this is actually from ovarian function suppression? You could just do ovarian function suppression and endocrine therapy, or give her chemo and endocrine therapy. And then 26 to 100, strong recommendation for chemo. And then premenopausal node positive, they're agnostic. They're saying all assays now are prognostic. But all these women on whatever trial, MIND-ACT, any trial you're going to look at, really it's only MIND-ACT and RxPONDER, everybody's benefiting from chemotherapy if she's premenopausal node positive, but the scores are prognostic, and there's a lot of information to be gained in terms of her outcome, whether you give chemotherapy or not. So ASCO also just published their guidelines a couple of months ago based on TAILORx and RxPONDER. Couple observations. If your patient is premenopausal, ASCO guidelines say the only assay you should consider is an Oncotype, not any other assay. The other data aren't strong enough to help you understand whether you want to do something. For node negative, strong recommendation, high quality of evidence. N1, there's a qualifier there that says the Oncotype score is quite prognostic for those patients. There appears to be chemotherapy benefit, but it is so prognostic, outcomes of these patients may be important to you. So the only other assay that's high enough quality evidence, although it's intermediate evidence according to ASCO, is from the MIND-ACT trial and the high clinical risk for the postmenopausal women, node negative and node positive. EndoPredict and Prosigna do not have adequate evidence that's a high enough value, and so those are called intermediate evidence with only a moderate recommendation to consider ordering these tests. Okay, what's next? I have 5 minutes to talk to you about the future. I'm sorry it took so long. Okay, deceleration of therapy. RxPONDER and TAILORx taught us a lot about decelerating chemotherapy. Can we decelerate other things? Can we decelerate radiation? Can we decelerate surgery? Can we think about using the score to help guide other types of therapy, systemic or local, that we use to treat these patients? So there's an ongoing trial that's about 50% accrued called M839. The other name for this trial is TAILORx. It is a trial looking at the question, if you are lymph node positive, do you benefit from extranodal radiation? Can you just radiate the breast and not radiate internal mammary, supraclav, axilla? And so this is a trial of women 40 and older, hormone receptor positive, with a recurrence score 0 to 25 and 1 to 3 positive lymph nodes. And these women are being they're being randomly assigned to extranodal radiation versus not. We're going to understand whether the score can help us decelerate this extranodal radiation, which we know significantly increases morbidity by increasing the risk of lymphedema. If you have a breast-conserving surgery, you get whole breast radiation with or without extranodal radiation. If you've had a mastectomy, you're randomly assigned to chest wall radiation and extranodal versus no radiation at all. It's about 50% accrued right now. There's a DEBRA trial being run by the NSABP. This is asking the question in women who are 50 to 70, who have a T1 cancer, recurrence score 0 to 18, do you have to radiate the breast at all? So this is breast-conserving surgery with or without radiation therapy. How about accelerating therapy? Or can we use other choices of therapy? This is an ongoing trial run by the West German study group called ADAPT Cycle. This is impossible to see, and I apologize for that. You take women who are at high clinical risk. You think this is a woman who probably needs chemotherapy. You do a core biopsy, you get an Oncotype score and a Ki-67. You give her 2 to 3 weeks of an endocrine therapy, tamoxifen or an aromatase inhibitor, or you could do ovarian function suppression and an aromatase inhibitor if she's premenopausal. And if the Ki-67, again at the excision or the biopsy after 3 weeks, 3 to 4 weeks, drops under 10%, they're then stratified. So it's a really complicated trial, but the trial really is looking at this intermediate group. If you start with a low Ki-67, you stay low, you're not part of the trial, and you're low clinical risk. If you are high, you stay high, you're not part of the trial. Here's the real trial. So you can have pathologically node negative, recurrence score less than 25, but you don't drop your Ki-67. Or your recurrence score is over 25, but you do drop your Ki-67. We'll randomize those. So now we're talking about not giving chemo to over 25. Clinically or pathologically node positive, if the recurrence score is 25 and under and they don't drop their Ki-67 those 3 to 4 weeks, they're randomized. Recurrence score over 25, node positive. If they drop their Ki-67 under 10%, they will be randomized. And then N2, N3, recurrence score 25 or less, and they drop their Ki-67. They're showing responsiveness to endocrine therapy in those first 3 weeks. What is the randomization? Endocrine therapy plus a CDK4/6 inhibitor versus chemo plus endocrine therapy. So we're going to take groups of patients who we haven't included in any of these trials, N2, N3, recurrence score over 26, but we're forcing us to see that they're showing endocrine sensitivity before we're willing to get rid of chemotherapy in that group. This trial's well accrued. It's not completed accrual, but it's getting very close. Lastly, premenopausal. I think there are a couple data gaps. One, I'm not going to talk about, but people have begun to ask this question because of all the controversies in premenopausal women. What if she's in the luteal phase of her menstrual cycle versus follicular phase? Does the phase of her cycle influence her recurrence score? Because you're getting a recurrence score at some static period of time in someone whose endocrine levels are flying all over the place. We're going to answer that with 2 trials that we have ongoing right now, investigator-initiated trials. But the real question is, in women who from TAILORx and RxPONDER seem to be getting chemo benefit, is it from ovarian function suppression or is it from chemotherapy? That trial will start either at the end of this year, but more likely in January of 2023. It will be run by the NSABP Cooperative Group, or the NRG in the United States. I am hoping we have substantial international interaction and accrual onto this trial. It is called BR009, but the acronym for it is called offset chemotherapy. That stands for ovarian function suppression endocrine therapy chemo. Here's the trial. Premenopausal. They already established what their premenopausal is. Hormone receptor positive, HER2 negative, node negative. If your recurrence score is 16 to 20, like TAILORx, you have to be high clinical risk, or 21 to 25. Or she's premenopausal, N1, 0 to 25. So those are the patients who benefited from chemotherapy from RxPONDER and TAILORx. They'll be stratified by their nodal status and whether their recurrence score is 0 to 15 or 16 to 25. Everybody will get ovarian function suppression. The question is, when you add chemo on top of it, is there any additional benefit? We can get rid of the question of chemotherapy or by recurrence score from this trial. So I'm flying through T1 to T3, and 0 and 1 as long as they meet the Oncotype score. 18 and older. Here's the definition for premenopausal. Time's up. I got it. Okay, so if you see, okay. Okay. It's going to be a large trial. It's 4,000 women. And if it plods along like other trials have done, it's going to take 7 years to accrue 4,000. So if we then say 5-year follow-up, we have 11, 12 years from now until we see these data. So this is why it's so important to me that we do this trial and that we really make this a worldwide trial to answer the question not only in the U.S. population, but the worldwide population, and really get us the answers for this trial. So my summary is TAILORx and RxPONDER have allowed us to decelerate chemotherapy in patients with hormone receptor positive, HER2 negative early breast cancer, and establish who will not benefit and insight into who might benefit from chemotherapy. They've allowed us to ask other questions about the Oncotype score. Can it be used for local therapy decisions? And then I think the biggest question we have, unanswered question that we need to answer is young women, premenopausal women, is ovarian function suppression enough? I think other questions about more cancer we can perhaps answer from the West German study group in the ADAPT trials about looking at endocrine responsiveness. Does that help us find a group of women with even higher scores or more positive lymph nodes who may be able to avoid chemotherapy? And I'll end there. Thank you very much for your attention.